Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. I wanted to talk about retreatment with immune therapy after an immune-mediated toxicity. So let's say a patient has a bothersome grade 2/grade 3 requiring steroids, and pick whatever one you want. And either for ipi/nivo or an IO-TKI regimen, what's your threshold to then reintroduce the immune therapy? If you know sort of what I'm asking, because I think that comes up in practice, right? You're like, well, it wasn't a terrible, colitis, and but it was, it was kind of bad, and I needed steroids, or it was LFTs that didn't resolve, or something, and I'm not really sure when to restart. So Moshe, we'll start with you.
So I think for me, the pendulum has swung. When I first started seeing patients, I was very concerned. If I saw an IRAE, an immune-related toxicity, they weren't getting the IO again. And then I kind of shifted and was saying, look, we've got all these specialists. We know how to manage the toxicities. We want the long-term benefit of IO. Everybody should get it. And I think, again, it all comes down to the patient selection. The two immune-related toxicities that I'm most concerned about, and as a general rule don't resume, is if it's something neurologic or cardiac. Yeah. But if we're talking more about colitis or transaminitis or even a dermatitis, I look at a few things. How severe was it up front? How much did it impact the patient's life? And how long did it take them to return to a grade 1 with immunosuppressants? Mm-hmm. So if it's, if somebody needed 4 months of relatively high doses of steroids plus another immunosuppressant, you might not want to re-challenge that patient. But somebody who had, an AST and an ALT in the 250 to 350 range, and they were on prednisone for a week and then quickly lowered and then lowered, that patient, you might be more likely to say, let's retry it. I do quote patients that it's probably a third of patients who had an IRAE and are re-challenged with an IO agent are going to develop either the same one or another one, and that's the discussion with patients.
Shuchi, what do you think? Same approach or something different?
Yeah, I agree. I mean, I just want to add that myocarditis and neurologic side effects, I don't re-challenge those patients with immune checkpoint inhibitors.
Right. Myocarditis, it's 50% fatal, so.
Right.
Yeah.
Exactly.
Yeah. But others, I agree with.
How about pneumonitis?
Pneumonitis, if it was something I managed as an outpatient, they needed a touch of steroids and then it resolved, it's fine. But if the patient ended up in the ICU and they were intubated, I might consider not using it. So I think it's
similar to Moshe's
exactly.
approach. Yeah, Monty, what?
I'm feeling like a real wimp because I actually don't re-challenge very much. If I get to that level of needing steroids and so forth, if their LFTs are up, to 250, 300 range, and they recover after a week of steroids, I'm not entirely sure it's necessarily IO mediated in that context, right? I mean, usually a real IO mediated issue is going to take weeks and weeks of steroids for resolution. Then I really have a very, very high threshold for, if at all, restarting therapy.
You're not restarting, but do you use scan results to decide?
Yeah.
If somebody's responding wildly versus stable, like truly stable 0-0.
Right. I think if someone's had an exceptional response and they've been on therapy already for 9 to 12 months, where usually at that point they're going to have the depth of response that they're likely to have, I would take that into consideration. But someone who's still relatively early on, 3 to 6 months in, I'm not sure they had the IO benefit yet. I think it's worth the discussion because the only way we're going to see a long-term clinical benefit for the patient with a deep, durable response is with IO plus. So I do have the discussion with them. And I lean heavily on the specialists, right? So we have gastroenterologists that are interested in this, rheumatologists interested, and we loop them into the discussion.
Which is an advantage at a large academic center that in the community they probably don't have the ready, pick up the phone and call, somebody who not only is a gastroenterologist, but has an interest in immune-mediated toxicity, right? That's a very different breed, but I agree with you. Last topic around doublets is duration of therapy. So again, as long as we've been giving immune therapy, we really have no idea what the right duration is. So we'll start with that as a premise. But Monty, are you following, when you're giving Cabo-Nivo, are you stopping at the Nivo at 2 years? What are you doing with the Cabo? Like, are you basing it on response? Let's take toxicity. If somebody has to stop for toxicity, obviously, let's take that out of the equation. But they have expected but manageable toxicities.
Yeah, I really leave it up to the patient. Look, by the time I'm getting out to 2-3 years on IO, the patient's usually developing some bothersome arthralgias or other side effects that make them want to stop. But if they're cruising along and if they actually feel more comfortable staying on therapy, I'll give them the option of continuing. I will bring up discontinuation, but more often than not, I've found that the patient, if they're completely unbothered by toxicity, really would prefer to stay on in that scenario. Okay. The one differences are in the setting of a CR, then I definitely have a stronger conversation around discontinuation, maybe even earlier than 2 years. But
so let's say, in practice, I think we see far less CRs than those near CRs, right? And there's a lymph node here, and there's lung nodules here, and there's a burnout something there. So what do you do with those deep PR patients?
I usually keep them going. I do. I'll have that conversation with the patient, but it's disconcerting to them to see that there's some residual disease lingering for the most part. So
well, residual abnormalities.
Residual abnormalities.
We don't know if it's disease.
Right. My brother-in-law's a radiologist, so I see that all the time.
And do you get any pushback from insurance companies? Because I've had instances where I've tried to continue the Pembro after 2 years, and the insurance will decline it.
Is that right? I haven't run into that yet, actually. Have
Me
you guys?
either, no.
I'm always stopping, so I haven't run into it. But Shuchi, what do you do duration-wise?
I mean, other than complete responders, I'm not stopping it. I think I probably have a lot of patients who will get super anxious even if I mention stopping. But yeah, other than complete responders, I keep going.
Moshe?
Maybe I haven't been in practice that long either. So.
I think patients want to stop the TKI. Meaning generally the IO, and I know we're talking about stopping the IO as per the trials, but I have the discussion at the 2-year mark. And for patients with a deep PR, I lean towards stopping. I think that patient's had a 90+% tumor burden reduction and has been on therapy for 2 years. At that point, they're kind of done. They don't love the idea of coming in every 4 to 6 weeks, depending on what they're getting. And, or they'll start by skipping every other infusion, like not showing up, and then they're like, "What are we doing?"
Voting with their feet.
Right.
I got to say, I mean, I stop in pretty much everybody.
Okay.
And frankly, I don't give them a choice.
Oh, really?
I mean, I say this is what the trial showed, right? We have level 1 evidence, right? And we don't have great analysis of patients who stopped yet. There's a little from 426. Hopefully, we'll have more, and I'm sure from the other studies. But I just say, listen, the way this regimen is designed is we're going to stop the infusions at 2 years.
The infusions.
The infusions, I'll get to the TKI in a second, but we stop the infusions. And I think it's partially reflective of the geography in which I practice in. They say, okay, doc, great. They say, sure, great, I'm awesome, I don't have to come in. TKI is more challenging, right? And as you say, it's really the one you want to stop. It's the one causing chronic toxicity predominantly. And I don't really have a standard practice, but I'm happy. I don't necessarily stop it, but what I tell people is take breaks as often as you want.
I find that if they've gotten to the 2-year mark and they're still on their TKI, they're on, either they're taking their breaks every few weeks without telling you, or they've already assigned, they're taking it Monday through Thursday in their pill box along with all their other medications. Or, they're on some schedule where they've figured out a way. I don't really find the chronic toxicity of TKIs to be within those first 6 to 9 months. I think once a patient has figured out how to be on it beyond the year, they know how to handle it.
They've kind of figured it out.
They figured it out.
Yeah, by definition.